All right, well, I want to go ahead and get started. It's trickling in. Yes, ma'am. There's one more exam, which is the final exam. I haven't decided if it's cumulative or not. Depends on how. I gotta see my evals first, and then. Let it not be? Okay, since you asked nicely, it's not going to be cumulative. So we're going to try to finish up all the cardio stuff. So if you look in section 3 of the class, or module 3, you'll see that there is the GI section, oncology, and the last cardio section we're going to cover. So yeah, and we have like 3 class sessions after this one, I think, still left before the final. So still a lot, but it's all right. We're shredding it down to size. We're going to put the material in the diet a little bit and get through it. So the exam is going to just cover what we do today on towards the last class, and that'll be it. All right, so non-cumulative, just like, and that's how Pharm 2 will run as well next semester, assuming I'm still teaching it, unless you guys get mad at me. Shh. Any questions? I have to go take a look at the exam to see if there's any high misses or give backs or anything like that, but any questions in particular? Somebody said it was a fair test, which is the most I'll hope for in an exam. May not be easy, but fair I think is at least what I can go for. Yes, ma'am. Yes. Oh, never mind. Okay. Very good. So let's go ahead and get back into it. I want to keep talking about our cardiology med. So getting into and again, this is kind of touching on hematology a bit here because we're going to talk about coagulation and clotting, all that good stuff. I want to start off by talking about our antiplatelet agents. Now keep in mind there's a difference between antiplatelet and anticoagulant. So we'll make that delineation as we go forward. Totally different medications we're going to use for those purposes here, right? So getting into it, obviously hemostasis is a very important thing. We want to clot off when we need to and make sure we're not clotting off when we're not supposed to, because otherwise it's where we get things like PEs and strokes and all things like that. So it has to be a pretty quick kind of process here, and there's a lot of medications that can come into play to try to alter this to make sure that we're either maybe more likely to clot off or less likely to clot off, as the case may be. So normally what you're going to find is that there's a pretty typical sort of pattern that goes along here, and normally your vessels are nice and smooth, and they try to prevent things like platelets and clotting factors from being activated to cause inappropriate clotting to occur, right? But what normally happens, say you have injury done to a vessel. So you have an injury to a vessel, that initial bleeding is going to kind of uncover, that injury uncovers certain things within the endothelial lining of that vessel, which will then start to trigger off the clotting cascade, and will trigger off the platelet cascade. And so initially what you're going to find is that you get this platelet plug that will initially sort of seal up the wound, right? And then from then on, you're going to see that you'll have those platelet plugs there, and then they kind of get meshed in with sort of a spider web looking sort of cement called fibrin that'll hold everything into place. And that's where you get that really stable clot there. And then eventually, do we need to keep clots around forever? Well, no, once you heal the vessel, excuse me, my enunciation is off today. Once you heal that vessel, then you will then get rid of that. And that's where things like plasmin come into play, and will then get rid of that fibrin, get rid of those platelets, and then now you have your healed vessel there. And so we're going to go through all those steps and see where we can interact with the system to either make it more or less likely for that to occur. So, as I mentioned, normally the endothelial surfaces are nice and smooth. We also have a lot of natural products within the bloodstream that help prevent us from clotting off inappropriately. So as an example, you have things like thrombomodulin, which lies on the surface of those cells, and they actually bind to things like thrombin. Now, have you covered the clotting cascade at all yet in any of your other courses? Very. Just started. Fantastic. Does anyone know another name for thrombin, what factor that is? It's actually factor 2. We're going to see that's going to be a really important one for our purposes. So when you're kind of thinking about like the most important clotting factors, I like to think about when you're driving, how do you hold your hands? Where at? 10 and 2, right? So 10 and 2, factors 10 and 2 are very, very important, as we'll see there. Again, most people, at least here in Orlando, specifically on I-4, do not follow that mantra, but that's okay. We also have other things like antithrombin 3, which circulates around and is really important for binding to thrombin and other factors, and will help to inactivate them. And also, I'm sure most of you heard of the substance called heparin before, right? Heparin you normally think about as a drug, but we produce heparin as well, and that actually helps to inactivate a lot of these clotting factors. It actually works with antithrombin 3 to make it work a lot faster, and we'll talk a bunch more about that in detail later on. Anyway, we have some other things as well that will be important for helping this process along. So for instance, we produce prostacyclins naturally that help to inhibit platelet activation, such that they stay in the inactivated state, kind of floating through the bloodstream without having any activation. However, other things like thromboxane A2 can help to stimulate this process. We'll talk about plasma later on. So there's a lot of different factors here, and I only mention these because this is where medications are going to be coming into play pretty significantly. And again, if you imagine what it would look like if you have this this fibrin clot occurring here, notice there's some red blood cells are kind of getting mixed up in there, but that sort of spider web looking sort of cement, that's the fibrin holding everything into place, and you can see some platelets kind of mixed up in there as well. So normally what's going to happen when you have the platelets activating, normally platelets are kind of in this globule sort of like resting shape, and they're not very reactive. What normally happens when you have an injury done to the vessel here, you have things like von Willebrand's factor that will become activated, and this will actually stimulate the activation of the platelet. Okay, the platelet will then kind of shrink itself in a little bit, and it ends up expressing these little sites on the platelet itself. And this is going to be really important because this is what helps the platelets to aggregate together. You can see here they kind of start binding up together, and we're going to look at ways that we can either stimulate or inhibit that platelet aggregation in order to help prevent our clots from forming, right? So normally, as I mentioned, that collagen gets exposed in the endothelial lining once that injury occurs, and that's where eventually you're going to find that von Willebrand's factor comes into play, thromboxane A2, ADP, all of these are going to be really important mediators to help activate the platelets there. And then again, once you have activation of platelets, you'll have that the 2B3A receptors that get expressed, and that's what's going to cause a lot of that cross-linking and a lot of that kind of clumping of the platelets to actually occur there. And again, we'll talk about the individual drugs that can affect these the systems here. Now, fibrinogen is also a really important factor. Fibrinogen gets eventually turned into fibrin, but that's also an important mediator to actually help hold those platelets together. So when you hit that plug there, fibrinogen is what's kind of holding them all in place. And then we'll mention ADP as well as it being a very important factor for activating these P2Y12 receptors. This is going to be another important drug site of action. So imagine you have a platelet here. There's going to be a lot of different things that can stimulate activation of the platelet itself, and we're going to look at a few drugs that can actually interact with the system and can help to interrupt this. So for instance, if I were to use something that maybe inhibited the production of thromboxane A2, you could inhibit activation of that platelet there, right? If you remember, thromboxane A2 is a byproduct of the arachidonic acid pathway. You guys remember that? Perhaps there's some test questions that may have been related to that, because remember, from arachidonic acid, what were the two pathways it could go down? So lipoxygenase going down the leukotriene pathway. What was the other one? Cyclooxygenase, right? Remember, COX enzyme turns it into things like prostaglandins. Thromboxane A2 is one of those products as well. And so that'll make sense because aspirin, how does aspirin work? Irreversible inhibitor of COX-1 and COX-2, right? So you're going to see here by working on that pathway, again, we'll talk more in detail about it, but by working on that pathway and inhibiting production of thromboxane A2, you can help to prevent platelet activation. And what do we give aspirin for most routinely? To prevent MIs, because it helps prevent platelets from activating and clogging up a coronary vessel, causing an MI, right? So again, this will make sense when we get into the actual details of why we use these drugs the way we do here as well. So you'll see this is going to be an important site. Things like ADP blockers are going to be an important site. Has anyone ever heard of like Plavix or clopidogrel before? This is where those drugs are going to work. And then we'll have specific ones that are blocking this cross-linking here occurring between the 2B3A receptors, preventing fibrinogen from causing that clumping to happen there, right? Less clumping means less clotting, means better flow through the vessel. So again, looking at things that naturally inhibit platelet activation, things like prostacyclin or PGI2 are going to be important ones. And again, naturally the vessels are such that collagen is not normally exposed, so von Willebrand's factor doesn't really do a whole lot there, okay? And like I said, when the platelets are inactivated, they're in that little globule sort of shape. They don't have those 2B3A receptors really being exposed, and such that also inhibits their activation. But let's get into the actual drugs themselves are going to help us to prevent platelet activation. Aspirin obviously is the first one we talk about because it's the most common one we're going to be using for antiplatelet activity. I'm sure most of you at least know somebody who's probably on aspirin daily. How much do they normally take? 81. What's another name for 81 milligrams of aspirin? Baby aspirin. Are they all babies that are taking this? No, but you'll understand why we give baby aspirin to adult patients, based on its activity, right? And so basically what aspirin does, it's an irreversible inhibitor of cyclooxygenase. I think maybe I've mentioned this before, or you've at least heard the term irreversible inhibitor. So what does that mean in terms of activity on the COX enzyme? Once it inactivates it, it's done, right? And platelets, if you recall, platelets, do they have their own like nuclei? They don't, so they can't produce new proteins and things like that. They just don't have the capability. So once a platelet is made, all the cyclooxygenation it has is all it's ever going to produce, and such that once it's inhibited by aspirin, it's inhibited for the lifetime of that platelet. And what's the lifespan of a platelet normally? About 7 to 10 days or so. So basically, by giving smaller doses of aspirin, because it's an irreversible inhibitor, you're going to find that as you produce new platelets, they'll be inactivated by the aspirin for the entire lifetime of themselves. So you really don't need a whole lot because of the irreversible activity. What do you think that means though if I have a patient who's, say, taking aspirin daily and all of a sudden they stop taking it? What do you think would happen to, say, their bleeding risk? Does it go right back up to normal when they stop it? So it would take a couple of days, probably 7 to 10 days or so, as they produce new platelets to get back down to normal. So again, this is a feature of it being an irreversible inhibitor, which is usually used for positive purposes here. And again, going anything up higher than, say, 160 a day tends to actually cause a more favorable activity towards inhibiting prostacyclin, which we mentioned is an antiplatelet agent anyway. So they found best effects by just using 81 to, say, 160 a day. Most people just use 81 milligrams a day, and they're totally fine. And again, remember the COX activation here, we're inhibiting this process here, so we're inhibiting conversion of arachidonic acid over into things like your thromboxanes and prostacyclins, etc., right? And normally we would use aspirin for what purposes? What other purposes can we use it for? We've mentioned fever. What else? Pain. What else? Inflammation, right? So again, this is the other purpose we're using it for, is to help sort of inhibit this pathway to inhibit platelet activation, right? So notice the differences in dosing you'd see there. So 81 milligrams a day is really good for prevention of platelet aggregation, but if you're using it for something like inflammation, the 81 milligrams is not going to do it, right? Unless you happen to be a baby. But giving bigger doses, they're going to have better activity against the inflammation, antipyretic effects, analgesic effects, etc., right? And again, do we like to use aspirin a lot in little kids? Not typically. Doesn't mean you can't use it, but just less typically. Maybe because of Reye's syndrome, right? Absolutely. So again, irreversible inhibitor going to be able to basically prevent that thromboxane A2 activation of the platelets for the lifetime of that platelet. So, but again, looking at the activities versus other NSAIDs, and some of these we mentioned before, but things like ibuprofen, you may only get antiplatelet activity for that 24 hours. So certainly there's a bleeding risk, but it tends to go away as soon as the drug is out of the system, because those are reversible inhibitors, right? So again, once they are off of the COX enzyme, then basically the cyclooxygenase can go back to its normal activity. That's no problem there. So while these other NSAIDs can carry bleeding risk, it's really only during that duration that the patient's taking it, versus aspirin can have a longer tail on it, so to speak, because the platelets are irreversibly inhibited. So what are side effects of our NSAIDs and aspirin that we would be looking for? We'll talk a little bit more about this in the GI section later on, but usually GI effects are the big thing, right? Because what other sort of important thing do, say, for instance, our COX pathway does for, say, the stomach? Prostaglandins help with that lining. It helps the stomach to basically prevent it from digesting itself, right? It has a nice alkaline sort of mucus barrier there, so that tends to be inhibited. Now, when you're just giving 81 milligrams of aspirin a day, you typically don't see a big issue with that. It's when they end up taking higher doses or for long term, where you can see things like peptic ulcer disease and whatnot. But obviously, the biggest risk you think about would obviously be bleeding, because again, those platelets are being inactivated there. Now, switching over, and again, who would you give aspirin to typically for, say, prevention of cardiac events? Yeah, certainly they have things like angina. You consider doing that because they already have signs of ischemia, right? Now, one of the big changes that actually happened recently is aspirin, instead of being used for primary prevention of cardiac events, they actually found that it has not been all that effective for that. But for secondary prevention, it is certainly beneficial. So if you have a patient who has a history of angina, CHF, MI, anything like that, any kind of ischemic heart disease, they need to probably be on aspirin at that point. But again, patients that are just taking it just if they have otherwise healthy cardiovascular system, they may not get a whole lot of benefit from that. But what else can we have? What else, other ways can we inhibit our platelets? Well, we have our ADP receptor blockers. You guys are familiar with ADP. You've at least heard of it, right? It stands for adenosine diphosphate. More importantly, what can it be converted into for our ATP, right? So Well, ADP itself can still be a signaling molecule. It can still be important for helping to activate platelets. And there's a couple of different receptors it can work with, either this P2Y1 or P2Y12 receptor. And basically, it will help to cause that conformational change in the platelet such that it shrinks in and you have all those little 2B3A receptors starting to be exposed. So if I were to prevent ADP from activating those receptors, what happens to the platelet? Kind of just chills out in the inactivated state, right? It just kind of is not going to be able to have that conformational change. It just stays in a normal resting state there. So normally we'll find that both receptors need to be activated in order for this to occur here. We'll find that our drugs are going to be very particular in interacting with this P2Y12 receptor, though. By interfering with one of them, you get the benefits of basically neither of them really being all that functional there. So we have a couple of drugs that fit into this category. Plavix is probably the first big one that is widely used, but certainly some other ones. We have things like ticagrelor or Brilinta, and then we have prasugrel or Effient are starting to be used a little bit more commonly now. And basically what you're going to find is that we will use this, and do you think this will be synergistic with aspirin? Why? They're working on two different pathways, right? One's blocking thromboxane production with aspirin, one's blocking the ADP receptor. So you do get synergistic activity here. And so we'll find that we can use these for things like patients maybe going in, say they have angina, they're going into the cath lab to have, say, for instance, a stent being placed, right? What's a stent? Anyone know? It's like it's a little metal mesh that you can put into the vessel that kind of keeps it patent, keeps it open there. One thing you'll note is that the body typically doesn't like foreign material kind of hanging out in that, and that includes those metal stents that actually get placed in the vessels there, and they actually tend to cause platelet aggregation. So you'll find patients who have a history of stent placement. Are there any high-profile people that got stents placed recently? Bernie Sanders did, actually, yeah. So he's probably on one of these ADP receptor blockers because he had that stent placed in order to prevent that stent from being clotted up with a bunch of platelets, right? And so he might be on ticagrelor. Who could say, right? Probably his medical team, maybe. But point being is that you will see that you can use this either for patients who maybe are not good candidates for aspirin. Maybe they have a history of peptic ulcer disease and they can't tolerate it, or maybe aspirin-induced asthma, things like that. But certainly we'll give it for patients who are going in for angioplasty, peripheral artery disease, a lot of different cases for use of these medications here. And they're oral, along with aspirin there, so these are good for chronic sort of management. Now, clopidogrel was kind of the first kind of really big one that came about there. There's a drug that came before, but there was an incidence of something called thrombocytopenic thrombotic purpura, and so because of that, it was a very sort of rare thing that occurred, but it happened, when it did occur, it typically caused pretty severe effects, sometimes fatal in some patients here, but this risk for TTP is fairly low with clopidogrel, so this is why we still use it. Obviously, the biggest risk from using these medications to block platelet activation would be what? What's the biggest side effect you'd see? Bruising and bleeding, right? So of course that is going to be seen there. There are also some other kind of rare side effects, things like neutropenia. If a patient became neutropenic, what would be a likely outcome of that? Infection, right? So again, these are things you'd want to look out for. Again, how would you tell if a patient was neutropenic? Get your CBC with diff, right? So again, you're going to be looking at that anyway, because how would you evaluate if a patient was bleeding? Look at the H&H, right? So again, you're going to be looking at ZBC anyway for these patients, and that can be a useful thing to monitor for it when you're looking at that, right? Again, so, and frequently we'll often find that patients, say for instance, they have maybe an NSTEMI and they're going to the cath lab or something like that, we'll frequently give them a loading dose of one of these ADP receptor blockers, and the benefit of doing that is what? Gets them to steady state immediately, right? So that way all those platelets are going to be inactivated because all the ADP is going to be blocked on those platelets, right? So loading doses are very beneficial from that standpoint. Now prasugrel and the ticagrelor that we're going to be looking at, they're starting to become used a little bit more commonly now, mainly because they have a little bit better antiplatelet effect than clopidogrel does. Main benefit there you're going to find is that they're more effective at preventing clots from occurring, but they're also going to be more likely to cause what? Bleeding, right? So again, it's going to be a double-edged sword there. The more effective it is at preventing clots from forming, the more likely it is to cause bleeding, right? So it's kind of just a known risk you're going to see with this. Now again, prasugrel has some kind of interesting, unique sort of side effects you're going to see with this, include things like hypertension, which can occur. Again, a lot of these patients are probably what already? Probably hypertensive to begin with. It's probably what was the pathogenesis for some of their ischemic heart disease in some cases there, right? Hyperlipidemia, again, these patients may also have this concomitantly, so these are things you want to be looking out for. Ticagrelor is going to have, again, very similar effects to prasugrel. Again, a little bit better activity here in terms of antiplatelet effects than you would see with clopidogrel, but more bleeding risk. This one's actually interesting because it will cause an increase in uric acid, which could be a problem for who? Yeah, patients with gout, hyperuricemia already, kidney disease potentially, and some patients will develop some dyspnea with that, which is, again, not necessarily explained by the action of the drug, but just something that was noted in the clinical trials there. Okay, so next up, so we have our oral agents, oral antiplatelet agents that are used most commonly. Now we're switching to agents you might see being used in the hospital setting, typically given via IV, usually continuous infusions. This is going to be for patients who are maybe going into the cath lab or maybe undergoing cardiac surgery, things like that. And so the first one we have here is going to be our glycoprotein 2B3A blockers, right? 2B3A receptors are necessary to cause that cross-linking between the platelets using fibrinogen. If I block that receptor, what does that do then? Yeah, they can't aggregate, they can't clot together, right? So, or can't cross-link together. So there's a couple of drugs we'll have that can do this, and that includes things like abciximab. Now immediately you already know what kind of drug is this? Monoclonal antibody, right? So you already know some risk associated with that. And again, this is actually a monoclonal antibody targeted specifically against that 2B3A receptor. So it's kind of it's like a heat-seeking missile essentially to block that and then activate that on the platelets. And you'll typically see this used in angioplasty along with things like aspirin, along with anticoagulants like heparin, and that helps prevent restenosis, right? So either during the procedure or maybe in the immediate aftermath thereof. And again, bleeding risk is going to be the biggest thing you're going to expect to see with these agents because, again, you're blocking those platelets from aggregating together. Rarely you'll see thrombocytopenia, and certainly immunogenic risk is a possibility, right? So maybe the first time the patient receives it, not a big deal. Let's say they have another heart attack, they go in, they receive this again, maybe they develop some risk for anaphylaxis, right? Or in some cases, you may actually find that the patient will develop antibodies that just inactivates the drug itself, which can be problematic, making it less effective. So there is some question, should you use this more than once in a patient? Maybe not. Similar to abciximab, have similar activity, but this one is not going to be a monoclonal antibody. It's called eptifibatide or integralin. Again, this is going to be another continuous infusion you'd administer to the patient to prevent platelets from aggregating together. Again, bleeding is going to be the biggest risk here, but a lot less immunogenicity, mainly because it's just not a big, bulky antibody that your body could potentially react to. And then the last one here, we have tirofiban. Now this one has the least immunogenicity risk, mainly because it's not a peptide like eptifibatide was. It's not a monoclonal antibody. So from that standpoint, very low risk of allergic reaction. Maybe a good alternative if they've had a bad reaction with some of the other ones there as well. But very similar side effect profile with the other two. Okay. Now I may ask you on a test, say there's a test question that came up and is saying, which of these two combination of antiplatelet agents would make the most sense, right? And so I may put it on as an answer choice. I may put something like eptifibatide and abciximab. Would that make sense? Generally no, because those are two 2B3A receptor antagonists, right? So you wouldn't want to do that. However, if I were to say put aspirin plus clopidogrel, does that make sense? Yes, it does, right? So again, being able to identify the drugs, linking them back to their classes, back to their mechanisms, and understanding does it make sense to put these two together or not, right? That can be something you may see because it's not uncommon for some patients to be on multiple antiplatelet drugs at the same time, right? Anyway, so moving into the anticoagulants. So when I say anticoagulant, these are going to be things that are working specifically against the clotting factors. And so you've seen this cascade before, right? Hopefully. Yes, you should recognize some of this. Remember, we have our intrinsic pathway, we have our extrinsic pathway, and then we have a common pathway, right? You're typically going to see that different monitoring parameters are also going to be used to monitor the activities of these different pathways here. So for instance, when you're thinking about ordering coags on a patient, what labs would you normally get back? PTT, right? APTT makes the same thing. What else? PT, what goes along with PT? INR, so you ever hear like PT INR is basically what they're looking at there. What other things can you look at? There's a few other ones, but those are probably the two most common ones you'd probably run into. And that makes sense when you're looking at this because you'll find that APTT is going to be a better measurement of the intrinsic pathway here. And then on the extrinsic pathway, PT-INR is going to be better for looking at that. And so, again, am I going to ask you on a test question, what does activation of factor 11 cause the activation of? Probably not, right? However, I may ask you a question to say, okay, well, this drug mainly works on factor 7. which monitoring parameter would you use to look at that? You'd be able to say, okay, well, I know factor 7 has a lot to do with the extrinsic pathway. I know PTINR is going to be good for looking at that. And that'll make more sense when we get into the mechanisms and how we monitor these medications there, right? So this will become more clear. Also note things like calcium is a really important activator of this process here. And in fact, when you have patients that are going on things like dialysis, for instance, what is dialysis? It's just an artificial kidney, right, where we basically draw out blood from the patient, filter it through a dialysis filter, and then put it back into the patient. Well, a big risk you have whenever you're taking blood out of the patient, putting it through a bunch of plastic tubing is what? We're about clotting actually occurring there, right? Because again, that plastic is, the blood's not used to having that plastic around. It can tend to cause activation through things like calcium. So we'll actually give things that can bind up calcium to prevent that from occurring there. So calcium is another really important factor that will help to stimulate activation of this pathway here. Anyway, so the important thing to note though is you're going to have the extrinsic and intrinsic pathway. They're going to be monitored differently, but they all end up meeting with the common pathway, right? And so this is where you have factor 10 coming into play, right? Which two factors I say are really important? 10 and 2, right? So 10 and 2 are going to be really important. 10 is going to be the start of this common pathway that will eventually feed down and lead to prothrombin being turned into thrombin, or factor 2A. Okay, very, very important. And note here, this is a positive feedback loop. So things like thrombin can then feed back and start to cause activation of the intrinsic pathway again, right? So again, it's a positive feedback loop because when you want to clot off, you want to do it pretty quickly, okay? And certainly we'll look at some inhibitors of this process a little bit later on, but these are the important things. So again, thrombin is important because that will help to stimulate production of fibrin, and fibrin is, again, is that final step, that cement that's basically holding all those platelets in place, causing the blockage there of the vessel to prevent it from bleeding any further, okay? So we'll look at some different drugs and how they can interact with the system here. Now, there's a couple of natural anticoagulants that we have. This will be important later on with some specific drugs. These are how we actually can help to inhibit the system. So for instance, we have things like antithrombin 3. This is going to be really important for how heparin works. We'll see things like protein C and S. These are going to be important things that are actually produced within, say, for instance, the liver. We'll look at some different ones here, okay? So getting into heparin first. Heparin is something that we produce ourselves, so this is a natural product here. Does anyone know where we used to get heparin from? We used to get it from like pigs and beef sources, right? So again, this is another one of those cases. Now it's more recombinantly made, so it's less of a concern, but back in the day, you'd have to ask like, hey, what's your religious preferences? Does that preclude them from getting certain medications, right? This could be related back to the actual source of the medication. So some people do not want any pork products. This would not be something you would potentially give them depending on the source that you had. But anyway, nowadays we have better ways to produce it. But essentially when you're looking at heparin you kind of can look at it like this big long sort of sugar chain that's basically going to be working with antithrombin 3 to help it inactivate activated clotting factors here. And you can see that it ranges pretty widely in terms of how big the molecule is, but and typically it's fairly large. And so if you ever hear the term unfractionated heparin, this is what we're referring to, right? This is just the OG original heparin, right? So what does it do? Basically, and I'll show you some pictures that will make more sense of this, but it works with antithrombin 3 and it will help to inactivate several different clotting factors. So 2, 10, 9, 11, and 12. Those are the big ones that are going to be affected here. And note, these are already active formed clotting factors that are floating around the blood. They will be inactivated with the work of heparin plus antithrombin 3. And basically what it does is it helps to make antithrombin 3 work about 1,000 times faster than it normally would. So it's kind of supercharging it to make it work a lot better to help inactivate these clotting factors there, okay? And again, the picture definitely speaks better than I can. So imagine here you have a long chain of unfractionated heparin. You see here it's working with the enzyme antithrombin 3, and here's, for instance, activated factor 10A. You can see here it basically facilitates that meeting of the two such that it can inactivate it much more quickly. Here's factor 2 and how that would bind together. This will become important later on when we're talking about the length of that chain and how it works. Because if you've ever heard of low molecular weight heparin, that's going to be a variety of heparin that we're going to see is going to be different than the unfractionated form. Right, you can also probably consider this to be high molecular weight heparin, although no one really calls it that, but unfractionated heparin, or UFH, if you've ever seen that, is what this is referring to. So basically, again, as I mentioned, we used to get it from things like bovine lung and porcine intestine, right? We will see that heparin itself is not going to be orally bioavailable. You have to give it either subcutaneously or intravenously, right? So for instance, if I'm trying to, say, prophylax a patient from developing a clot, say for instance they're going to go say on a trip over, they were going to fly to Australia, right? It's one of the longest flights you can be on. What's the problem with patients being on a flight for a really long time? DVTs, because they have a lot of venous stasis, right? They get off the plane, all of a sudden they've got a palpable cord on one leg, and it's all red and swollen and painful. Well, to prevent that, you can do things like prophylactic heparin beforehand, and so that would be given maybe subcutaneously to prevent a clot from occurring, or you can give it fractional treatment. So if a patient comes in, say for instance you had a young lady coming in, she was just put on oral contraceptives, she was a smoker, coming in for chest pain, what are you thinking? PE. I think that's like classic, right? In that case there, you could actually give heparin in order to help prevent any further clotting from occurring. In that case, would be sort of a treatment dose, and that would be given via, say, a continuous IV infusion in those cases there, okay? This is also very frequently preferred in pregnant patients, mainly because it doesn't cross the placenta, doesn't cross the blood-brain barrier, not found in breast milk, so it can be very beneficial from that standpoint. We'll talk about that later in OB-GYN next semester. But yeah, so it's very, this is basically the one standard anticoagulant we had for a very long time. Now, how do we monitor for its activity? Basically, because it tends to have better preference for affecting the intrinsic pathway, you're going to see that this is going to be more affecting the APTT. So classically, this is the most common way we would monitor for the activity of heparin, is by measuring the APTT. And basically what you would do is look for a ratio between where your patient's at versus what the normal would be, right? So for instance, you may be shooting for a therapeutic ratio of, say, 1.5 to 2.5 times longer, because how is APTT measured? What's the units? In time, it's in seconds, right? So again, you're looking at that ratio, because again, if it's anticoagulated, it takes longer for it to clot, so that would obviously cause the APTT to go up in those cases there. So you're looking for that ratio to show that while my patient's taking that much longer, maybe 2 times longer to clot in this sample than the normal would be, and that shows that they're very well anticoagulated for those patients, okay? And again, prophylaxis or treatment of things like venous thrombosis, PE, MI, angioplasty, any of these things are going to be very good indication for using unfractionated heparin. Obviously, the big risk here is going to be bleeding. Certainly, that's something you're going to see, and that can be measured with APTT. The higher it is, the more likely your risk for bleeding is, which is why we have a lot of protocols centered around our titration of heparin. So for instance, if you ever get a chance when you're on rotations or something, go look at one of these order sets, and you'll see that for heparin, it'll say, hey, if the APTT comes back at this, reduce your dose by 10%, or increase it by 10%, or give a bolus and then increase the rate by 10%. They'll do things like that to make sure they can titrate it, and basically the nurse is the one that's doing most of that titration. You gave the order, and then they're acting on that to try to keep the patient's APTT right in range. Okay? Now, whenever I mention antidotes for anything, this is a good thing to know. It's a very good thing to know. If there's any antidotes for your drugs here. So for instance, because a patient who's actively bleeding, if you want to fix that, usually a good thing for the patient, right? You don't want them to have a stroke or something. And so in this case here, you can give the drug protamine sulfate. This will actually bind to heparin and inactivate it. Okay, so if I had, for instance, a patient case that patient was receiving heparin for a DVT, and the nurse was not being very, she wasn't really watching her APTTs like she should, and all of a sudden the patient's bleeding. What would I give to reverse the effects of heparin? You'd say protamine sulfate, right? So again, we'll talk about some other antidotes for these drugs a little bit later on as well. Now, another rare thing you can see with heparin is what we call heparin-induced thrombocytopenia, or HIT. So this is the thing you're going to see in patients who have been on heparin for a while. So say a patient gets admitted to the ICU for a PE, and they're on, say, heparin for, say, 5 to 10 days or so. Basically what you can see is it will have a pretty significant drop in their platelet count, usually about a 50% drop in their platelets, and this will be evidence of HIT. And I think, well, where do the platelets go? They just magically fly off out of the patient? They're activated, right? So this is what actually happens, where your body will develop an antibody against heparin and something called platelet factor 4. The heparin and platelet factor 4 kind of hang out with one another, and your body develops an antibody against that. What's interesting is that antibody actually ends up activating the platelets. So even though you're giving an anticoagulant, you've now caused an immune reaction that's causing the patient to clot. So it's kind of counterproductive in those cases there. And so in which case we actually have to give alternative anticoagulants to make sure the patient's not going to be clotting off anywhere too terribly inopportune. And so we'll talk about some of those drugs a little bit later on here in just a few minutes. But anyway, so that's a big sort of thing you want to watch for patients who are on long-term heparin. Okay, is heparin-induced thrombocytopenia. And again, if you were to give that patient heparin later on, you were to re-challenge that patient, guess what would happen? They immediately go back into the same thing. So you would never want to give this patient heparin ever again. And in fact, you'd be very careful by giving them any heparin-based product, which we'll mention a little bit later on. So Getting into that, let's talk about our low molecular weight heparin. So what would happen if I say took heparin and I were to say chop it up into smaller pieces? Well, you see that it will still be an anticoagulant, but has slightly different activity, and it gets a little bit more specific for which factors it's going to be affecting. So for instance, heparin, unfractionated heparin, affected 2, 9, 10, 11, and 12. You tend to find when you get into your low molecular weight heparins, it's much more specific for just affecting factor 10 and 2, okay? So by getting it shorter, you're going to find that antithrombin 3 is not going to be able to be facilitated as well for all those different factors. It gets much more specific for 10 and 2. And actually has a little bit more preference for 10 than it does 2, and I'll show you a picture that makes sense of that. There's a few different ones, but the only one I've ever actually seen used clinically is called enoxaparin or Lovenox. I'm sure most of you probably heard of Lovenox before at some point. Very, very commonly used, and I'll talk about why some of the benefits of using that over heparin are in just a few moments. Basically, it's going to be working on the same pathway as heparin, the same exact mechanism. It's just because it's a shorter molecule, you're going to find that it does not work as well on factor 2A, but it works still pretty well on factor 10A, as you're going to see there. And you can look at the ratios between the two here. Unfractionated heparin from 10 to 2, it's a 1-to-1 ratio, but low molecular weight heparin is going to be much more in favor of factor 10 being affected here. Right, which makes sense because if you're looking at a low molecular weight heparin, you see here that factor 2 is just too big. You can't really help to facilitate its binding there to antithrombin 3. However, factor 10A is just right. It totally works just fine for that. Okay, so that's kind of the big difference there. So because of that, and because enoxaparin is not really affecting a lot of those other factors like 9, 11, and 12, do you think this will have a very good effect on the APTT? Or it will have a very pronounced effect? Not really, because it's not really affecting the intrinsic pathway a whole lot. So you can't actually use APTT to monitor low molecular weight heparins, and that was actually a benefit for a while. People are like, well, I don't even have to monitor this stuff. I just give a fixed dose, patient anticoagulated, I don't have to worry about it. And in fact, that was a big benefit for a long period of time. But it basically has no consistent effect on APTT. We do know that we have to watch out, though, in certain patients because low molecular weight heparins are much more renally eliminated. You do have to adjust for that. And then you may have patients who are, say, very obese or maybe very small. We do this, basically any kid over at Nemours that gets put on enoxaparin, we do monitor. We do laboratory monitoring because we know they're at risk, because we know they may have altered pharmacokinetics. And instead of doing an APTT, which is not going to be reliably affected, what we do is an anti-factor 10A assay. Okay? So anti-factor 10A is basically showing me, well, how much activity am I getting out of my factor 10? Okay? You're going to see that as this goes up, as you get more anti-factor 10A activity, it means that your factor 10 is working less and less well. And so this is what we're going to do for the majority of our pediatric patients. If you have patients who are in the extremes of weight, we can do this as well to make sure that we're dosing them appropriately. Okay. So that's a big thing there. Most of the time, though, the other benefit here is that while enoxaparin has to be given parenterally as well, either IV or sub-Q, it has a much longer duration of action. So whereas heparin, I may have to give, say, 3 times a day for prophylaxis or as a continuous infusion for treatment. This one I can either give once or twice daily. So again, very nice from the monitoring parameters, very nice from a dosing standpoint. So this is why this became much more popular than heparin in a lot of cases for many patients because of that. However, we didn't have good access to anti-10A assays for a long time. They were very expensive. There were send-outs in a lot of cases. That's now changing, and more places have access to it. And so actually now what you're starting to see, and you may see this when you go on rotations, is that patients who are on heparin, instead of using APTT, they're actually switching over and using anti-factor 10A. Now, does it make sense that heparin wouldn't have an effect on 10A, anti-factor 10A levels? Well, yes, because it affects factor 10. So some people are finding that's even a better monitoring parameter for heparin, low molecular weight, unfractionated heparin, I should say, as well as low molecular weight heparin. So that may be something you may see as a little bit of a difference there. But could I use APTT for Lovenox? No, it will not affect it reliably, right? So that's kind of the difference between those two there. So there's less bleeding associated with these drugs as well, and then also much less risk for HIT, but it is still possible, right? So be very careful to ever give a patient who has a history of HIT low molecular weight heparin. Probably steer away from that in most cases. Now, to get even more specific than the low molecular weight heparins, we just have a pentasaccharide sequence, just 5 sugar molecules long, and this is called fondaparinux or Arixtra. And so by getting even shorter, it has almost no activity against factor 2 and only factor 10 activity. So again, the monitoring parameter for this would be anti-10A levels, just like you would see the low molecular weight heparins. This one was actually used because it had, for patients who have a history of HIT, this had almost no cross-reactivity, and so this was very safe for patients to receive there, and so that's where it was being used for a while. Again, I don't see this one used as commonly, but mainly for those patients who have that history of HIT, you can end up using this. Okay, so any questions on that? I know we didn't get through a ton of this stuff, but that's okay. It's short in time. Any questions, sir? Yeah, you do anti-10A levels, yep, for sure. Because then again, it only affects factor 10, so it makes sense that you could use that for that. Right, yes, sir?
So you can use the Fonda Aranax with history of HIT?
Yeah, so again, you still want to be cautious, right, but it has the lowest cross-reactivity, so that would be the safest med to give. And so you could ask a test question to say, hey, you have a 65-year-old patient who's coming in with a DVT, has a history of HIT. Which one of these would be the safest to administer? And Elixir may be an answer there, right? Or I may choose something that doesn't affect factor 10 or 2 at all. You see, that may also be a safer option as well. So we'll look at those potentially next week. Let me see if I have any questions on the board. I think everyone's still shell-shocked from the exam, so that's okay. If nothing else, I will then see you guys next week, and we'll keep trucking along. Yeah, we'll go from there. I'll take a look at the exam, see if there's any high misses, and we'll see if there's any give-backs, and I'll make an announcement if there are. Okay.